All right, good afternoon, everyone. Again, my name is Robert Hess III, and I am here today to help present an overview and best practices of the Strategic Prevention Framework. For those of you that have not participated with us previously, I have about 15 years of experience working in health and human services. A significant chunk of that has been working in prevention. I'd say about the last 10 years has included various aspects of prevention work, as well as spending a lot of time working in health systems across the United States and in a few other countries. I'm going to skip our slide about what we do, but we do lots of things. And if you have questions, reach out to us. And so our learning objectives for today are to provide an overview of the strategic prevention framework, as well as to describe the process for conducting community-driven needs assessments. So we're going to try and cram a lot of content into a very short window of time. And for those of you that have participated with us previously, this is all new and updated content. And so hopefully you'll all get a chance to participate and engage and learn a couple of different ways to think about and conceptualize the strategic prevention framework and the work that we all do. So I wanted to start kind of contextually, and I did this a little bit in our previous webinar 2 weeks ago, and really wanted to convey kind of the drivers of the strategic prevention framework. And a lot of that stems from the federal government. And so while they are two different independent mechanisms, the strategic prevention framework is most often funded through substance abuse block grants, which are a federal level funding program that is focused on substance abuse prevention and treatment. So these dollars are available to all 50 states. As far as I know, all 50 states do accept and receive these dollars from the federal government. And you can see that the program objective is to help plan, implement, and evaluate activities that prevent and treat substance use. And so, or specifically abuse, excuse me. So the substance abuse block grant targets the primary or focused populations, which include pregnant women and women with dependent children, IV drug users, tuberculosis services, early intervention for HIV and AIDS, and then you see here primary prevention services, and this is where we really kind of stem or get a lot of the funding for the work that we do in prevention work, at least in the public system. SAMHSA, which is the Federal Substance Abuse and Mental Health Service Administration, who administers the substance abuse block grant, requires that at least 20% of all block grant dollars are focused on primary prevention of substance use. And so these strategies are not directed at individuals for treatment, but they are focused predominantly on prevention and environmental contexts. I think personally, it's really important to understand this because these drivers, I think it's every 3 to 5 years, if I'm not mistaken, but there are annual requirements that the states must communicate to the federal government what their plan is for substance abuse block grant dollars. So a lot of this money does get put into treatment. And so if you have detox facilities or rehabilitation programs or medical assisted treatment, typically in association or in conjunction with detox and everything, a lot of that's coming out of these dollars. But part of that is this discussion around what and how the state could, would, and should be allocating its prevention dollars, because again, 20% of these dollars have to be allotted or allocated for prevention. Now, I'm presenting this because that's an opportunity, especially within the state of Arkansas, for you as community-driven and community-based providers and organizers to collectively kind of engage and have a voice in the process and help the state identify kind of priority areas and how these issues or how prevention dollars could be allocated more efficiently. And so I want this to kind of be in the backdrop of your minds. And as far as I know, based off of my last, I think now 6 or 7 years working in Arkansas, there seems to be a very positive kind of flow of information from what's happening on the ground to what's happening at the state. And I'm hoping folks will agree with me on that. But if not, there is opportunity to kind of enhance communication so that the state kind of is aware of and knowledgeable of current needs. And a lot of that's going to funnel into our conversation around needs assessments. So as our first kind of question you see here on the side, we're going to use a rating system because I think that's easier for folks via chat box to communicate. But how familiar are you with the substance abuse block grant? So if you're very or extremely familiar, type a 5 in there, and not at all, type a 1 in there. And then, of course, you can see the scale anywhere in between. So go ahead and give me a response. How familiar are you with the substance abuse block grant? All right, 0. Wonderful. Yeah.
I know, wasn't.
So I'm glad because that means that we're learning something, right? And so there's
Right.
definitely opportunity for everyone to kind of take some time to investigate this. I think last session I included a link to the current Arkansas block grant plan. And I know I recited quite a bit of content out of that plan. So I would take some time, if you haven't already, to just plug into your Google browser Arkansas Substance Abuse Block Grant application. And it's not a super huge document, and hopefully the language will be familiar to you, so it'll be an easy read. I want to say it's about 40 pages, so whether or not that's huge for you, I'll let you decide. But it's definitely going to be very informative, and I think it will help everyone kind of understand, really the flow and kind of the macro lens of how the state is approaching substance abuse, and specifically the mechanisms that are in place to plan for it. And I say all of that because, as I mentioned, that funnels into how the strategic prevention framework is implemented and why we're using this model. And so the strategic prevention framework is an evidence-based process model, and I'm going to be very emphatic around process because it is not a clinical tool. It's not a diagnostic. It's not an intervention in and of itself. It is a process model. And so there are 5 stages. You can see them there. They're the colors. Assessment is the first stage. The second stage is capacity or capacity building. The third stage is planning. Fourth is implementation. And the fifth is evaluation. Which is really centered around reassessment. And then these steps of the process are all kind of focused and centered around sustainability and cultural competence. On the left-hand side, you're going to see that there's some dates over there, and those are just related to upcoming trainings that are in this particular series. And so on those dates, we're going to be covering topics related to each of these different steps and phases of the process. They're not going to be explicit as far as describing what the step is necessarily, or even operationalizing the step, but it's going to be a relevant topic. And we use this model just to kind of offer an array of different technical assistance. And again, before we started recording, I mentioned that there's kind of a little library of recorded trainings that are now available that have been presented previously, and those are all available on YouTube. And so we want to make sure we can definitely get you those links to that channel if you're interested in kind of learning more about each step of this process. And so today we're going to focus a lot on kind of conceptualizing the process as a whole. And then we're going to dive specifically into the assessment phase, as I described in the introduction. So still focused on describing the process, the strategic prevention framework was designed to promote youth development, to reduce risk-taking behavior, build assets and resilience, and prevent problem behaviors across the lifespan. It was specifically designed to focus on youth and adolescents, although this process model has been applied to a number of different demographics and populations. So I've used it personally among older adults. I've used it among specific demographics such as African American communities or LGBT communities, and different topic areas. And so there's a lot of application for the process because it really helps build community. It's really effective at community-driven processes, I guess is the best way to say that. So the idea behind the strategic prevention framework is to use findings from public health research along with evidence-based prevention programs to build capacity and sustainable prevention. This in turn promotes resilience and decreases risk amongst individuals, families, and communities. So according to SAMHSA, again, the federal government, the SPF steps require states, territories, federally recognized tribes and tribal organizations and communities to systematically assess their prevention needs, build their prevention capacity, develop a strategic plan, implement effective community prevention, and evaluate their outcomes. And we're going to describe different ways to do that. So one of the things that's really pertinent about the strategic prevention framework is that it's a public health model. And public health as a field is very prescriptive and has a very interesting approach behind it. And so quick pause, and we can see our question on the right-hand side. So how familiar are folks with traditional public health approaches? And that's going to determine how long I spend on this slide. So if you don't mind sharing with me in the chat box, so whether you have an undergraduate in public health, an associate's degree in public health, a master's degree in public health, or have just worked in public health looking at traditional approaches. All right, it's looking like we have a pretty knowledgeable crew. So I'll make this a quick review. So looking at traditional public health, of course, we want to use data-driven approaches. So using the study of epidemiology, prevalence and morbidity of disease, preventing exposure, assessment, and disease lethality. And so essentially, public health uses a medical model, and substance use doesn't, and behavioral health conditions in general aren't as definitive as malaria or the measles and the mumps. There's not necessarily, the diagnostic criteria is not necessarily as black and white, but we can still use substance abuse epidemiology. So looking at use patterns, looking at the number of individuals that the first onset of substance use, or the first trial of substance use, as well as the people that have used substances in the last 30 days or the last 60 days, depending on how our surveys are designed. We can look at overdoses in the emergency department, or if we needed to look at death due to substance use, we would be able to track those things based off of morgue reports and death certificates and things like that. One thing that's interesting is we're going to conceptualize preventing exposure to substances. And so that is really going to be talking about that first use. And so, whether we want to start or use the concept of like gateway substances such as tobacco and alcohol that are legal and migrate into more controlled substances or illegal substances. I'm not going to put a firm definition on this. I think there's still a lot of discussion about some of those being gateway drugs, so to speak, and even including marijuana in there, or prescription medication if it's taken as prescribed or if it's not taken as prescribed. I think there's a lot of gateway opportunities. But so when we talk about preventing exposure and also differentiating between substance use and substance abuse, I hope you guys are comfortable with leaving that a little bit nebulous, but basically defining that as when it becomes a problem, whether that be addiction or illegal use of substances or inappropriate use of substances. We'll leave that a little vague, and I hope you guys are comfortable with that. And then disease lethality is another interesting conversation in the context of substances, because smoking cigarettes will eventually kill you, but if you're using heroin or meth, the lethality of those drugs is going to be more significant or higher. And so there is this construct around substance use lethality or substance lethality within the context of substance use. And that's going to come into conversation as we discuss kind of prioritizing strategies and prioritizing needs. And so the public health approaches are also dynamic, so continuous reassessment of community needs. And I think we talked about that in the strategic prevention framework. Population level approaches, and we described this a little bit in our last session about overview of primary prevention. So looking at different methods for information dissemination, education alternatives, problem identification, and environmental strategies. And the other conversation that I think is really important that we can draw from public health is the life course perspective. And so when we're talking about prevention, especially with substances, a lot of times we do focus our attention on youth and adolescents, which is really critical, because if we can prevent or stop someone from experimenting or trying and exploring with substances in adolescence, then the hope is that when they become adults and they have a fully developed prefrontal cortex, they're not going to pick up a recreational drug habit later in life. But really considering kind of the opportunities across the lifespan. So I think we are all very familiar at this point with the opioid epidemic and how some of those things are situational. So maybe you injure your back and have to have surgery, and then you become addicted to your painkillers. And some of that can happen at any point in time as far as age. Or across the lifespan, whether you be a child, an adolescent, a young adult, midlife, or later in life. And so considering the life course perspective, as well as, the impacts of like long-term alcohol use or long-term tobacco use. I know you guys are all familiar with this, but just trying to push us a little bit into a public health model so we can think about it a little bit more concretely, or at least within this framework. Are there any questions or thoughts before I move on from the public health approach? I want to take a quick pause and allow folks to type in the chat box if you do have a question, or if anything I've said you disagree with or you want to add to. We have a very knowledgeable and competent group. So anything that you guys think that I missed? All right, I will circle back if folks end up typing anything, but I will continue to move forward for the sake of time. So one of the other really critical components, and again, I know that you guys are all very familiar with this, is that the strategic prevention framework is a community-driven process. And so I was being a little cheesy and fun in here when I wrote that this means that the community is in charge while providers, or us, maintain responsibility of meeting our contract requirements. And I think, I don't know if you guys have had the same experiences as I have had. Sometimes the community can become a runaway train, and it's hard for them to get them to value the fact that we have a deliverable due, especially if they're not necessarily as interested in it, or if it's not an interesting and fun deliverable. And so I think that there's always a fun balance that comes into play. But it's very important, that we continue to remain focused and dedicated to the community-driven process. And so I wanted to ask the group what the best strategies that you use or that you have seen to ensure that you have a community-driven process. How do you, in your work, ensure the community remains in the driver's seat? And I'm going to pause until I get an answer on this one. So I'm hoping a volunteer will start feverishly typing for me. It can be something simple, it can be something formal or informal, the way that you allocate allocate your agenda, the way that roles are distributed or powers distributed. But someone type in the chat box for me on how you ensure that the community remains kind of in charge of driving the process. Yeah. So keeping the community involved in the planning process is very important. Continuously engaging with gatekeepers, absolutely. What about other folks? Working with coalitions when someone else is in charge? Yeah, that's a great opportunity. I think in some of my work, and I hope you guys will keep typing away for me, in some of my work with some of the coalitions that I've done or worked with and helped configure, or that I've been in charge of, or whatever it may be, ensuring that meetings are structured in a way that community members are invited to meetings. They know where they are. We make meetings as flexible as possible for community members, and so sometimes that means that we can't meet during the workday because folks are at their jobs or in school. And one of the things that we would always wrestle with is that we, as kind of the professional behavioral health field or prevention field, this is our day job, and so we don't want to be working every evening, but then the community is at their day job and can't participate with us. So the way that we would find a balance is some of our meetings would take place during a typical 9 to 5, but then at least, whether it be once a month or whatever the schedule would be, but we would always have an evening opportunity for folks, so that if they were working and still wanted to engage with us, that we would have at least kind of like daytime meetings and evening meetings, and allow some variability and flexibility there. We also, of course, would nominate or allow the community to nominate people into leadership roles. We had specific requirements that, like, the chair of a coalition would have to rotate every 2 years, or I think it was every year. It was every year, and be nominated so that there's constantly fresh leadership. We would create subcommittee opportunities that the community would fill. And again, that leadership would rotate, and it also gave people, a lot of times those subcommittee meetings are what would happen in the evenings, because those were typically more community based and driven. And so whether that be, kind of like our data analysis group that focused on our needs assessment, or whether that was our outreach and engagement group that focused on, engaging community members and member recruitment and stuff like that. Lots of different strategies, and I think that you guys really hit them all. So we're going to start diving into the needs assessment process next. So before we jump into that, I want to take a quick pause again and just ask if there are any questions around the strategic prevention as a whole. This was a pretty kind of down and dirty review. It was real fast. And I'm happy to connect to additional resources if you guys would like, or if there are other questions about the strategic prevention framework. So I'll take a quick pause. If you have questions about the strategic prevention framework specifically as a model, would you type them in the chat box for me? All right, I will keep going, but please feel free to type them in there and we will circle back if necessary. So we're going to start talking about the needs assessment process. And this isn't something that folks do all the time. It's not like a monthly process, but annually, I would hope that there's some level of kind of reassessment. And then whatever your contract requires, some states require that every 2 years, every 3 years, every 4 years, that you do go through a formal needs assessment process. And so we're going to talk about that. The most important thing that I'm going to say is that there are 1,001 different ways, there should be an S on that, to complete a community-based needs assessment. There's formal community-based participatory research models and frameworks, and all kinds of research techniques and tools, and we'll talk about a few of them. But fundamentally at their core, we're going to use a scientific method kind of as like a high-level process through which we should be facilitating our needs assessment. And so I don't know if you guys remember, or if specifically if you have children in elementary or middle school who should be learning this, how familiar are folks with the scientific method? So again, we're going to use our rating scale. If you are super and extremely familiar, type a 5 in the chat box for me. If you are not at all familiar, type a 1 in the chat box for me. There will not be a test at the end of this. Perfect. So it looks like there is some level of familiarity, which is great. And we're just going to use it kind of as a conceptual model. So again, there's no specific test and we'll get through it. So we're going to start off with kind of the purpose and defining the purpose of your needs assessment. In this context, it's partially identified for you, right? So we know that the funding is driven by the substance abuse block grant. We know that there are some specific drivers, so we're going to be talking about a prevention issue, some problem in our community. However, there's a lot of opportunity to focus and refine the purpose based on whatever your collective group decides it's interested in. And so I've seen coalitions that organize based off of age, race, sex, sexual orientation, gender identity, immigration status, veteran status. I mean, there's a lot of different groups and ways in which you can organize yourself. Some groups focus on geographic areas, so they're going to focus on a school district, a city, a county. Some groups focus on substances, so whether it be alcohol, tobacco, marijuana, or comorbidities, so looking at suicide and substance use, or diabetes or liver disease and substance abuse, or COPD and tobacco, or they focus on specific, I'm using the word eligibility because you can see there's a reference to Medicaid, or whether that be Medicare, or whether that honestly even like veterans in the VA. And sometimes that happens because Medicaid is offering additional funding for this that may complement kind of block grant dollars or what the work currently is. So identifying your purpose is really should be identified through the community and the community-driven process, and recognizing that sometimes there may be divergent purposes or divergent issues. And so I remember one coalition I was working on, we had started due to some funding for substance use, and it was very early in kind of the development process of the group norms and figuring out who we were as a group. And there was a lot of discussion around, well, substance use is great, but half the room were, behavioral health clinicians, and they were really interested in suicide prevention and trying to figure out how we could marry the two and or break off. Did we need to start another coalition that was suicide specific, or was there a way that we could kind of structure or position ourselves to be able to focus on these two different communities or two different issues, excuse me. And then there was, this conversation around, well, are we going to only focus on youth, or is there a conversation and interest on focusing on adults? Because there was another kind of line in the sand, so to speak, on persons' interests. And so, all of those things had to be discussed and teased out. And fortunately for that particular group, we were able to kind of create subcommittees that focused on these particular issues and areas or topics. And cohesively, the group was still able to kind of move forward together. So I'm being very interactive today. So if you don't mind sharing with me what your target audiences are. And so whether that be youth or marijuana or opioids or older adults, but use your chat box and just give me a sense or an idea of the different target populations that you are focusing on in your prevention work. And I mean, it can be geographic as well. So maybe it's specific to your county or whatever that looks like. Okay. Yeah, so folks that are saying across the lifespan, tell me more if that is geographic, if it's, again, there's lots of different kind of qualifiers that we can use. But give me a little bit of a sense. Is it substance use exclusively? Are there other topics that are in that mix? Is suicide a conversation? Is recidivism and juvenile justice a conversation? Okay, perfect. All right. Good, good, good. Yeah. Perfect. That's really helpful because I'll also make sure that I include some of these topics as we continue to move forward. So the next step after we define the purpose is we want to do some preliminary research. And I am inserting my own methodological approach here and going to focus on qualitative research as this first step, because you're going to see later in the scientific method where we're going to focus more on quantitative methods. And so the first step on research is really helping you refine your focus. And so this is going to be including a literature review, so looking at academic literature, peer-reviewed literature, looking at best practices, looking at gray literature, so like needs assessments from the state or other local communities, any information that already exists. From there, we want to really construct or kind of help chisel. So I should have drawn this on here and I didn't, but we're kind of using a funnel approach, right? So it's starting off really broad. What are the substance use issues in Region 6? Or what are the suicide and mental health issues in my particular county? And so we're going to see if any information exists. But of course, it's not going to be specific enough. It's not going to define our exact geographic location. So while we might find some information on the whole state of Arkansas, it doesn't tell me about my particular county or city or this school district or whatever it is. Or it doesn't include the Hispanic community, and that's my target population. So that's when we start kind of going down this funnel and getting a little bit more specific. And some of the best strategies are key informant interviews, so looking at professional interviews, case studies, personal narratives, social network analysis. So some of these techniques, are really going to the experts on the ground and identifying what their thoughts are. So whether that be a substance abuse treatment provider in the community or a city council person or congressional candidate or office holder, whomever those might be, a researcher in that particular field from the university, and asking them what they know, as well as asking community members themselves. And that's really where those personal narratives and case studies come into play, is really asking the community. And if that's by going door to door, or if that's by asking the members on your coalition, about their thoughts. Social network analysis, I'm not going to spend a lot of time on it, but it's really fascinating and important, I think, in our work, especially when we're talking about substance use. And so it's essentially, kind of like the degrees of separation, 7 degrees of separation, which I'm sure most folks are familiar with. But it's going to tell us that individuals that are most at risk for substance use are going to be interconnected, and whether they be connected because of their dealer who is providing the substances to them, or whether they're connected by some other kind of like social factor or cluster. And so by being able to kind of chase down the network, it might be able to help address some of the issues that are going on in the community, and whether that be the supply of substances or clusters of even suicide attempts, which is known to happen, lots of different drivers. So once we kind of have a better sense of what the context is, and this is kind of a rank ordered or a linear process is the way that I'm describing this. It doesn't have to be, but it is kind of a recommendation. So do some reading first, ask some experts, and then from there you're able to kind of identify some key questions, and that's what I would bring into focus groups. And so in the focus group, a town hall, whatever you want to call it, you get 10, 25, hopefully not 100, but if 100 people show up, that's great. That's a lot to try to navigate, but you get folks in the room and the community in the room, and you start asking them informed, targeted questions based off of your research so far. One thing that I think is a really significant opportunity is to do root cause analysis. So when you have 25 people from the community sitting in the room, and you're talking about, why we're having such an opioid epidemic and so many overdoses in the emergency department, gives you the opportunity to have them inform your root cause analysis. So what is actually happening, and why are people, using opioids at the extent that they're using them? And that's really, going to help, having the community define that for you is going to be really helpful. And then ethnography is really a great kind of contextual component as well. And this probably could go up in between level 1 and item 1 and item 2 in there, but using a ride along. So, go spend time in the community. And this is, of course, really great, or what's great about a community driven process is that these people live there and you likely live there as well. And so by going to new neighborhoods and spending time or becoming a participant observer in the process is also a great opportunity to help kind of whittle down your research question and understand or gain knowledge about what is actually happening in the community. So based off of all of that, and this typically a community needs assessment is a little less formal, so I'm kind of putting this out here due to using the scientific method as a framework. I am not accustomed to a lot of prevention coalitions writing down a formal hypothesis and then testing it. But it is conceptually kind of the work that we're doing. So I'm going to keep it on here. We're going to keep talking. So based on your initial findings from your focus groups, literature review, key informant interviews, all of that, we want to define some specific research questions. And essentially what we're doing, you see this on the bottom of this slide, is that we're defining specific questions and assumptions that are going to translate into our quantitative research tools or our community-based survey. And so we want to spend some time kind of thinking methodically about what is our initial data telling us. We've just spent all this time with community members, and what are the key trends that we're seeing. So, if you're skilled in qualitative data analysis or know someone who is, we would use methods around like coding and recursive abstraction and a number of other tools to help identify the themes. But even just by having multiple members of your coalition attend the focus group and then sitting in a room and debriefing afterwards and saying what stood out to you is going to help you really understand, or at least kind of build some consensus around what you should be asking on your needs assessment. I think that one thing that I do observe quite often when working with coalitions on needs assessments is we kind of skip that qualitative step and we jump immediately into designing a survey. And that may be because we're very confident in our knowledge and understanding of the community, or very well informed as far as what the current substance use trends are and what the literature says. And I would really just advise or encourage folks to take the time to go through our qualitative research process that we just discussed before designing or going into your quantitative process. And so this hypothesis building is really centered around helping identify what your questions are going to be. And so then we get into your survey. So again, as I've just described, we're going down the funnel. So we're going real abstract, and now we're able to get more specific and ask really targeted questions. Based on your qualitative data collection and analysis, you're going to design your quantitative experiment, or essentially we're going to start testing questions that we've put up there or designed. So of course there's a whole bunch of statistical and empirical considerations when designing a survey. And I'm not going to dive into all of those because we would be here for months to go through it. But considering your study design, so what types of tools are you using, making sure that your survey, that you have enough participants, your sample size, and making sure that that's reflective of your target population. So considering your recruitment methods, specifically, so if you are targeting adolescents that are between the ages of 14 and 21, or whatever that may be, whatever your age cutoff may be, that live in a particular region, we want to make sure that all of those participants, they meet those age criteria just from a participant eligibility perspective, but also that they represent kind of the demographics of that community. So if that community is incredibly diverse, racially, ethically, from an educational perspective, economically, from a social economic perspective, and we only recruit, middle class Caucasian youth, it's not going to be representative of the rest of the community. So, just keeping that in mind, and if that requires that we oversample in particular areas to make a more representative pool of participants, then just think that through. Thinking about the survey logistics, so how are you actually going to administer it? Is it going to be online, so using like SurveyMonkey or another tool, and how that gets distributed, whether it's like Facebook ads or posts or an email list, or maybe you have to contact us and we'll send you the link. Using a telephonic tool, that's typically more expensive, so I wouldn't assume that gets used super often. But if you were doing a population-based sample or a population-based survey, I think that there's some opportunity there. Or just literally going door to door, knocking, finding patients at a rehab center, things like that. And all of that is going to impact or skew your data positively or negatively. So if we're looking at substance use trends and we're only asking people at AA meetings and rehab centers, then obviously everyone in our sample has had some direct contact with addiction or substance use. And that might be appropriate if we're looking at, what got you into recovery, or what helps you stay sober, what are your resiliency factors and protective factors to keep you kind of in that tertiary prevention side. So things to consider. There's no wrong approach necessarily. It's only wrong based on, kind of what your goals are for the survey. And then of course we want to get down to the questions that are going to be asked. Important, the number of questions, making sure that we're not, filling out or creating a 5-hour survey or that has 100 questions on it. That's going to take people a really long time. The types of questions, of course, that impacts, kind of how people respond, and how they're going to be asked. So very specifically, like the wording of them. And it's important to really test that. I have unfortunately learned the hard way, that you design questions that you think, because I have designed questions because they made sense to me when I wrote them, but then when people started answering them, the answers didn't make any sense. It wasn't at all what I was attempting to get from them. And that was my fault because I had my own bias in the way that I worded the question, or it was a leading question, or the language was too abstract or advanced, or wasn't in a way that people knew or didn't properly interpret what I was asking. And so I definitely am an advocate of testing your questions, having 1 or 2 people or 5 people or 10 people from different backgrounds and different settings take the survey in advance and then give you feedback on it. That's a really important opportunity if you have the time to do that. So one of the things that I think is important when doing this, and I know I described it already, is making sure that you have access to a statistician or a formal researcher or someone that really knows how to do this stuff. So on the right-hand side, there's just kind of some kind of generic opportunities, to see or to have someone help you out with this process. And so, of course, there are people in our communities that know how to do this. They work, they're the math teacher at the local high school, they're teaching intro to statistics at the community college, or they're doing advanced statistics at the local university. And those are people, in my experience, I've found very willing to participate and help, especially if I've designed something and it's just, give me an hour of your time to review this and give me your feedback on the questions. Of course, you can use LinkedIn or other resources to find local experts. This is my favorite, ask your college or student or college age or college student children and their friends. It's amazing how much we forget as we grow up. And so one of my professors when I was in school used to always say, I've forgotten more than you've ever learned. And I think that's probably quite accurate. I forget 90% of what I'm exposed to. And so it's always great to ask people that are connected to these institutions, whether they be your children, your kids' friends, or yourself, or whomever your partner might be. Of course, you can request technical assistance, and obviously the most costly would be to hire a consultant, which may not be feasible, but that opportunity does exist. So once we collect all of our data, there becomes analysis, right? So we've collected all this. We had 100 people participate in our survey, or 1,000 people participate in our survey. Now, what do we do with it? And so the analysis process, of course, is a multi-step and very dynamic process that helps to draw conclusions from the data. So there's formal statistical analysis, which I think, honestly, a lot of people stop there, or they do that and or they skip that altogether. I guess you can overemphasize it or you can underemphasize it. So of course there are lots of techniques and strategies and tools on how you can do this. Again, having that resource, whether it be someone on the committee or coalition and or someone from a local university or school that's helping you do this, having appropriate statistical analysis is going to be important so that you know that your data is valid and is really telling you what you think it's telling you. And there's lots of fun ways that you can present that. The interpretation process is really where the coalition and the community should come back into the picture. The actual statistical analysis requires technical skill. I've definitely worked on coalitions that have statisticians and epidemiologists and folks that are able to do that, but I would say a majority of community-based coalitions don't have those resources in-house, but they're really, really helpful in interpreting that data. And so, by regurgitating that data back to them, saying, hey, you helped us design these questions and identify needs. This is what it's telling us. Can you help us interpret it? What does that mean to you? Because again, they're experts in their community. They know what's going on. So I would absolutely recommend bringing that data back to them and allowing them to participate in the interpretation process. And then we're starting to move kind of into some of the decision making, but helping to build consensus around what this actually means. I've worked with lots of groups that get really stuck in this process. One person's interpreting it this way, another person who's very boisterous and loud and a strong advocate feels that we need to be doing X, Y, and Z, even though the data is telling us A, B, and C. And so consensus building can be very challenging, especially in a community-driven process where you have, mothers and people that are in rehabilitation themselves or sober themselves, and then you have, clinicians that work with folks all the time. It's just a very mixed group, right? And so building consensus can be challenging, but there are specific techniques that can help you build consensus. And so I've listed a couple of them. I'm not going to go through them in detail, but I would encourage you, if you're struggling with consensus building or getting folks to get along or to agree, I would encourage you to look into some of these. I use the Delphi technique almost all the time because it's very effective, helping folks kind of rank and prioritize findings or what we do agree on. And all of these can be done through a simple 10-minute or 5-minute facilitated activity. And frankly, in certain coalitions and in certain instances, I've literally had people write it down on a piece of paper and turn it into me. And then I just present what the decision is afterwards. Some of that's due to expediting the time it takes to discuss things. And other times it's because the conversation is intense or tenuous and we just need to make a decision. So definitely look into some of those techniques. SAMHSA has some pretty good resources available as well. So if you were to type in, SAMHSA delegation, you might be able to find some of that information and content. It stems from their strategic prevention framework site, which is a really great resource. So another part of the analysis, though, is not just looking purely at some graphs and some charts or things like that, but also constructively interpreting the information to say, what is it telling us, and looking at resource mapping and gap analysis. And so the needs assessment is going to tell you about what the prevalence or morbidity or how many people are using substances or people's attitudes about substances. But we also want to look at what resources exist in the community, what help is available, what do people do when they have a substance abuse problem, and that's really where this resource mapping comes into play. So we want to look systemically at formal providers, at authorized leaders, at informal providers, and even unauthorized leaders, especially in rural areas, which I know Arkansas has a lot of rural and even frontier areas. It's important to look at the informal networks because they can be absolutely incredible assets and resources. And that might literally be one person that has been sober for 25 years. And maybe they're not super public about it or super out about it, but they're willing to meet someone for coffee and be a sponsor. Or it can be a suicide attempt survivor or a retired clinician that used to do, clinical therapy, but no longer does. Some of those resources in the unauthorized leaders and informal provider network are really important, especially in those rural areas. And so I don't want to lose sight of that. But you can see, kind of looking at, your formal provider list, as well as key decision makers and influencers and create a list, literally a list, and preferably kind of a geographic map of where they exist. And so one example, and this is drawn from the Substance Abuse Block Grant, and you can see it's referenced here as the SAPT block grant. It's the exact same thing. So SAPT stands for Substance Abuse Prevention and Treatment Block Grant. And the other acronym is just SABG, which is the Substance Abuse Block Grant. Exact same thing. But so this is drawn from Arkansas's plan, and you can see that geographically they have done this resource map. And they identify the number of substance abuse providers in these various regions. So what's important about this is we're going to use this and overlay it with the number or with the need for substance abuse providers in these geographic areas. Of course, your particular needs assessment might be restricted or limited to one county or one particular region. And this particular map is a little old. I think I guess it's 2016, forgive me. So it should be pretty accurate. But so it might be one county or one region that you're focusing on. So you would be doing this maybe at a city level, a county level, or a regional level, but same concept, right? And so you map out where the needs are, where the resources are, and you overlay where the needs are. And so when you're doing your survey, you'll want to collect some type of geographic data point. So whether that be an individual zip code, it would be difficult to get their exact address because that would be identifying information, but it could be their county. There's some type of geographic identifier that you'll want to ask, so you'll be able to do this effectively. And so zip code is often very easy to use because you can also analyze that pretty easily. And so when you do your needs assessment, collect your zip code, you'll identify needs based off of that. And then when you'll identify the resources that exist in that particular area, you'll be able to do this resource mapping. So then you can create a matrix. And this is kind of a watered down, completely generic and made up. This data is not real. But if you were able to identify, if we know, I'm just going to walk this through conceptually, and I'm going to use outpatient services. So for outpatient services, we know that the typical physician or provider, and we can ask them to find this out, one doctor, an outpatient primary care doctor, can see approximately 2,000 people in a year. That's a typical panel or caseload for a primary care doctor. So we know that there are 8,000 people in this community. So we need 4 doctors that can each see 2,000 people a year, right? And so we see here that we have, this primary care doctor, this primary care doctor, this primary care doctor, this primary care doctor, right? Or this organization offers primary care, considering these as agencies. So our need is met because we have 4 providers. And I know this is not advanced, so I'm not going to spend a lot of time kind of chewing it apart. but this helps us identify kind of where the unmet needs exist. And you can do all kinds of fun like proportions and scales and fun statistical stuff to kind of reinforce the message that our needs assessment says, that we need, a licensed clinical substance abuse provider in this particular county, and there isn't one, for 20 miles or 40 miles or, an hour drive, whatever that is. And so clearly that creates the case for helping identify additional resources. Now, I am assuming that most of you know your communities well enough that we can probably just say that right now, right? Like we know exactly where the gaps are in our community. And this creates an opportunity for us to quantify it. And so thinking that through when you're designing your survey, and again, going back to kind of the purpose of your survey that we talked about here, is if the purpose is, part of your purpose can be to identify the resource gaps and limitations in our community. And then when you're coming down to your quantitative questions, you'll be wanting to ask the questions around access to care and things if that's an issue. So all of these things are kind of interlaced, and that's I hope that that's not lost as I'm kind of walking this through in a linear fashion, because all of these steps of the process are interconnected. So again, this is kind of atypical in a needs assessment, but the last step of the scientific method is really looking at a conclusion where you compare your hypothesis to your findings. And so if your hypothesis, and we go back, let's see, where is it? Here we go. So if your hypothesis is that youth ages 12 to 18 are smoking marijuana after school, and we think that that's what's happening, or if we think that there's a lack of after-school activities combined with minimal parental supervision. So we might ask questions on our survey around like, hey, youth, what do you do after school? And we might ask faculty or nonprofit organizations in our key informant interviews, like what after-school activities do you ask? Or parents, are you home when your child gets home from school? We would design questions to get at our hypothesis here. And maybe what we find is that there are 20 organizations that provide after-school programs, and parents are home every day after school, immediately when their children get home, and all of those things. So we would essentially compare our hypothesis to the findings and say that our hypothesis is wrong. There's plenty of after-school activities. The parents are definitely home. There must be another reason why youth are using substances after school. And so we would have to continue to reinvestigate or explore other things. Again, this may not be as applicable to this process because this is typically very formal, where we would state if we accept the null hypothesis or reject the null hypothesis. Again, this isn't empirical research, so that's not always used. But there is this continuous quality improvement process where if our findings are not supportive, or if there's still some lack of clarity on particular risk factors or behaviors, then we can go back and reassess or ask more questions. And I have worked with groups that after their needs assessment, they've gone back and held another focus group and said, hey, this is what our findings are, and we need some help interpreting it and figuring out what it means. And so there's always an opportunity, and you can do that at any point in time. So we are at our time for today. I do want to take an opportunity to ask folks to type any questions into the chat box, and I'll make sure to answer them. In order to get credit for participating in today's session, we do need you to go ahead and follow this link to complete the online survey. I'm going to type it for you one more time. There it is in the chat box. But that doesn't need to be completed within the next 48 hours to receive credit. My phone number, that's my cell phone number, so you can call me if you would like, or text me, as well as my email address if you have specific questions, or if I mentioned a resource that you are interested in. I'm happy, absolutely happy, to send it or share any information or resources that I have. And just a last caveat before we go is, I mentioned it previously, but we have been recording all of these sessions, and they are available on YouTube. And so if for whatever reason you would like that link, please reach out to Lorraine or Chuck's or myself, and we'll go ahead and get that to you. So you can share it with your colleagues, or if you missed a session, or if you are interested in previous topics. So here you go. I'm looking for any final questions. And if you do not have any, then we can adjourn for today.